Thank you for taking your time on this Thursday night to join us for AO Link Unlocking Orthopedics. This is the third season of AO Link, and so we're really excited to be hosting this and hopefully give you some pointers going forward. We have an awesome set of panelists here, and we're really excited to get started for this season, especially this session that's hopefully going to be really pertinent for you guys going forward over the next couple months. We really are excited about a partnership we've started with the MSOS, or the Medical Student Orthopedic Society. It's called Fracture Friday. Every Friday we'll be posting videos in conjunction with MSOS of bite-sized orthopedic trauma cases and trauma concepts to help improve your knowledge in little 1-2 minute videos that'll be animated and help you get a little bit more knowledge quickly. From some of the AO faculty that are here, that are the stars and the people that are pushing the field forward in orthopedic trauma. And so we're really excited about this collaboration. So look forward on the Instagram and other social media platforms for this. Furthermore, AO North America is a great organization that can expand your skills, grow your network, and really help you succeed in your future and create a network and colleagues that you really can't get anywhere else. And so consider becoming a member of AO. This is a little QR code for you to become a member, but there's so many opportunities associated with this. So hopefully AO Link is not the first, but if it is, can lead to many more opportunities and touches with the AO organization. AO Link is a unique webinar series that's focused on medical students and increasing their knowledge. It stands for Listening, Integrating Network, and Knowledge. This is the third season of it. It's not a graduated course. It's not the 300 level. It's just a different set of committee members and panelists that are going to talk to you about orthopedic concepts, mostly trauma, but all sorts of things that are important for your orthopedic rotations and orthopedic knowledge and musculoskeletal education and medical school. That's hopeful you can share with your other medical student colleagues, and they can join in future sessions going forward. This is a message from our AO North America president on the importance of education in the AO and inspiring the next generation. And Dr. Lee's commitment to pushing forward medical student and resident level education through the AO. Another topic about AO Link and by our chair of the board, Amy Kapatkin, talking about the AO Link is just the beginning. The AO has so many educational opportunities, but Link is a great opportunity for medical students to get involved. And then we're fortunate enough to be joined by the AO Link founder, Dr. Tim Aker. He says, as you begin your career, there's nothing more important than your foundation of knowledge. But Dr. Aker, you want to touch on what Link means to you and what your kind of thoughts and visions was for it, a little brief statement.
Yeah, thanks, Patrick. I mean, briefly, years ago, for many years, we've been doing this Monday afternoon chalk talk with the medical students where it's just a surgeon and the rotating students, and the intimacy, the collegiality of learning first names and really diving in was really just fantastic. And the med students raved about it. And I thought, well, I don't know that there's any platforms like that nationwide for some students that may not have those opportunities. And thus came this idea, and now I'm happy to say it's flourishing and in its third season. And yeah, from my standpoint, of course, patient care comes first, but resident, fellow, and student education is right there with it. And when you're starting to become an old timer, what could be more important than passing the torch to the next generation? To help the next generation learn how to do all the tips and tricks and things you can't necessarily just find in a textbook, Patrick.
Perfect. Well, thanks for that. We're hoping to kind of take this on as a challenge and educate the folks of you on here and improve your hopefully understanding of orthopedics. Lucas Marchand and I are your co-chairs for the season, so you'll be hearing a lot from us. We have a bunch of faculty that will be joining us as guest faculty throughout the different sessions, so hopefully you won't be too bored by our voices. Dr. Marchand is an orthopedic trauma surgeon at the University of Utah. Did his fellowship training at the Shock Trauma Center in Baltimore, Maryland. And we're super excited to be able to be here with you today and throughout the season to hopefully educate you. Today we have guest faculty Eden Epner from Vanderbilt University. She's a PGY3. She was a medical student with Dr. Aker and I at the University of Texas at Houston. So we chose her as one of our guest faculty because of her success as a medical student. So we know that she can educate you on what to do good because she did good herself. And then Ellie Sato is recently graduated. Congratulations, PGY5 out of the University of Utah, who's doing her trauma fellowship at Harborview, and as well did extremely well as a medical student. So she also, we thought, was an excellent person to join us today to help educate those of you on the call. We don't have any relevant disclosures, but here are disclosures for the chairs. These are the upcoming sessions. We have two that are already picked, and then hopefully at the next one we'll be able to update you guys on what the rest of the sessions will be going forward. Milestones is a unique online assessment-based platform that can help improve your surgical proficiency. It's really helpful for medical students and beginning residents to help with their surgical education. So check it out here. It's a super cool, unique AO resource. So just some ground rules for today. All your microphones have been muted and your videos are off. If you have any questions, we really want you to have questions. We want you to participate. We want to be able to answer what you want to know. So feel free to type those in the Q&A box. All of us up here will be going through the Q&A box and answering those either online or typing them in. And we'll present these to the faculty as it goes. And then the chat box is for faculty and staff, and is not for the participants, and so we will just use the Q&A box going forward. Again, earning a merit badge at the end of your session today, you'll get an email. You can claim your creditly badge, and if you come to all 10 of these sessions, you'll get a final merit badge. And so please make sure you're logging in and getting your claiming your creditly badges so you can get credit for this, put it on your CV. So let's get started. We're going to tell you how to leave the orthopedic rotation well-liked. What can you guys do to make sure that you're impressing your knowledge and your success as a medical student and with the attendings and residents that you're rotating with? Our learning objectives today are 3 phases: how to succeed in the clinic, how to succeed in the ER, and how to succeed in the OR. And we'll go over all this stuff, talking about where are the pointers that are good for medical students. The 3 pillars of the orthopedic rotation: clinic, how can I be helpful in clinic? How can I not just be taking up space in the clinic hallways? ERs, how can I help the residents? How can I make sure that things are getting more efficient? I can help in patient care. And then OR cases, how can I adequately prepare, and what are the resources available for me to make sure that I'm prepared for these cases? So I'm going to turn this over to Lucas. I think you're on mute there. Zoom etiquette.
As Pat had sort of mentioned, there are 3 pillars to most rotations and definitely orthopedics. You have the OR, and then sort of ER, or kind of being on call / helping residents, fellows, attendings, and then clinic. And I think what's important to understand is that in all 3 phases, you're going to interact with different people. And it's important to sort of keep this in context. So at each spot, you're very likely to interact with, like I said, residents, and your role and how you work with or help a resident is going to vary depending on the setting. And the same can be said about working with fellows, attendings, and then finally staff. And I bring this up because the I have seen numerous medical students rotate through a service and do an absolute excellent job, but do a poor job of ingratiating themselves to staff, such as the MAs that work in clinic or the orderlies that are cleaning the OR between cases, the nursing staff that works on the floor, or people working around the hospital and other capacities of patient care. So just keep in mind that at all points, you have a role. You need to respect that role and find a way to be helpful and ingratiate yourself to those people that are around you. The last thing I would say about this, just this whole webinar in general, this is sort of like my public service announcement for this webinar, is that you're going to get opinions realistically from 4 people: myself, Pat, Ellie, and Eden. And what I would say is the 4 of us are fairly like-minded. We've actually all worked with each other in the capacity of either being residents or medical students together. And I would say because of that, we see the world and the role of a medical student in on an orthopedic rotation very similarly. And you all are going to rotate across hundreds of different centers across the US. And the way that role is perceived at different centers is going to vary. So you can take some of what we say with a grain of salt, but I certainly hope to impart upon all of you guys some foundation of ways to navigate the system, to be helpful, and provide you with like some hard and fast rules with how to leave the rotation well liked.
So we're going to talk about the first phase of being a medical student, and that's clinic. And so the first thing to talk about is understanding the clinic and establishing the expectations you have that you have in the clinic that you're at. You know, you can rotate at 100 different places, and you'll have 100 different expectations as the medical student in clinic. So the best thing you can do at first is to understand what the expectations are. Do medical students see patients? Do they go with patients with the PA? Do they go with the attending? Do they go with the residents? If they do see patients, do you see new patients or only post-ops or follow-ups? And then how are patients presented? How do they get, are you responsible for their post-op or their post-clinic, making sure they get their follow-ups, or is that what the attending is going to do? Because the worst thing you can do is see a patient, present them very well, and then 35 minutes later, the patient's still in their clinic room. They don't have follow-up, and then everyone's mad because the clinic room is being used, and then the patient's upset that they've been sitting there for 35 minutes. So if you can see patients, we talk about the orthopedic history and physical. You know, you'll learn on your medical student rotations about the history and physical from the medicine doctors and from the family medicine doctors. And by all means, that is extraordinarily important. And that is something that needs to be done. But when you come to the orthopedic service, we're a little bit more focused on certain things. We don't care quite as much if you've had your flu vaccine, if you're getting your routine follow-ups for your colonoscopies. We're mostly dealing with isolated or polytrauma situations where there's a specific reason or focus you're here. So focus the information related to the trauma, the injury, the complaint that the patient has. We want pertinent medical history. Again, the fact that they didn't get their flu vaccine isn't extraordinarily important, but the focus on, do they have diabetes? Are they having active cancer? Are they on dialysis? Do they have previous infections? And then physical exam. You know, an abdominal exam isn't extraordinarily important for someone that has knee arthritis. But knowing the special exam maneuvers in the joint areas, around the joint, or the areas that you're looking at, is important for you going forward. So we're going to start with this patient. This is a 9-year-old patient that presented to, sorry guys, our offices are under construction, so I'm at home. This is a 9-year-old patient who presented to clinic with left hip pain. She's in the total joint clinic. So Ellie, what kind of things are you hoping the medical student is going to do prior to seeing the patient in clinic?
Yeah, I feel like it's really important to use your resources and look at the medical record. You know, medical students usually have access to the records the same as we do. So you can usually look at like patients' pre-op labs if they have any, what medications they're on, their last note if they saw like a PCP, kind of like you mentioned earlier, and then go through all their images, like their most recent x-rays, if they have any previous x-rays, comparing the two, looking at them, and then reading that the radiologist read after you make your own interpretation, I think is really important. So then you kind of have a gist of what you actually need to ask the patient, so it makes your visit quicker with the patient too. So I think you can do all that before you actually walk into the room. I actually
Yeah, I
want to mention too, as far as like setting expectations for clinic too, is definitely ask about dress codes too, because you don't want to be the one person in scrubs when everyone else is in business casual for sure.
It's a great point. You know, that the worst thing you can do is to show up to clinic in scrubs and everyone's wearing business kind of formal attire, and you're kind of like, ooh, bad news. But I think it's a great
Yeah,
point.
sorry.
Go ahead.
Along those same lines, I think like something that I tried to do as a medical student was I would just ask residents who had already been in clinics with those attendings, like what I should expect and what they would expect of me to smooth that transition so that you're showing up and you already know sort of what to do and what they want you to do versus playing catch up when you arrive. And that helped a lot.
Yeah, I think that's a great point. You know, preparing yourself. This is not something that's unique to clinic. This is kind of pertinent, what Eden and Ellie said. This is pertinent to the OR, pertinent to the ER. You know, prepare yourself. Get as much information as you can prior to doing anything that you're doing. So talking to the medical student that was just on service, talking to residents that just came off the service, so that you know what you're getting yourself involved with. But I think one of the things that I think is super important for you guys to do is to look at the imaging prior to going to see the patient. That's oftentimes something that's missed by the medical students. They kind of grab a chart, they're a little bit nervous, they don't have to go see a patient, present it, and then they just go in and see the patient. So look at the imaging and know what you're getting yourself involved with. Even though you may not know kind of exactly what the image is showing you, but it's super important for you guys to look at the image prior to going. And then I would, prior to going to clinic, a little bit of knowing what yourself getting involved with, just read about some of the common physical exam maneuvers for the total joint clinic. So, you know, total joint clinics, I see mostly hip and knees. So what are some common arthritis maneuvers for the hip, and what are some common arthritis maneuvers for the knee? And just know a couple of those. And, you know, you don't need to know all this little tiny tricks and little super specific exams, but if you know McMurray's, or you know, you can range the hip and talk about where their pain is in the hip, that's all super important.
And I think too, just going off that, if you don't remember to do a certain exam in the room, or if you don't know how, don't lie about it. Like, don't come out and present a patient and be like, oh yeah, their leg lengths were equal. Cause like, then we'll go in there, or the attending will go in there, and they'll know that you didn't look at the patient's like limb lengths. Just say, oh, I forgot to do that. I'll make sure to do that next time or something. I think is really important.
Yeah, again, just something that goes across all fields. Never say you made these kind of white lies we talk about, or half truths. It's all say, if you didn't do it, you didn't do it. If you don't remember whether you did it, then you didn't do it. And just be honest. You know, we're not expecting you to know and have the answer for everything. The whole reason you're in medical school is to learn. So if you didn't know about the physical exam maneuver, you didn't do it, it's all okay. Just be honest with us. History, you know, it all depends on what clinic you're in, but you know, how long have they been having pain? Most orthopedic histories involve pain or some type of injury. So how long have they been having pain? Where is the pain? Treatments, surgeries, and then the general health of the patient. Is the patient pretty ambulatory, walking, healthy, walks 4 miles a day? Or did they come in, you can hear their oxygen machine working, they're in a wheelchair, they can't really stay awake. And so what is the kind of physical status of the patient? And the medical history, of course, is always really important. Lucas, do you feel like physical exam for medical students, they oftentimes kind of are afraid to touch the patient or to examine them? And what kind of tips do you have for them to kind of get the patients to allow them to examine them?
I sort of think that the most important thing you can do, first of all, is introduce yourself appropriately when you enter a clinical exam room. So if you're a medical student, I'm Lucas Marchand. I'm a medical student working on the orthopedic surgery service. I was planning on getting a quick history from you, performing a physical exam so that I could share it with the team, and then they could come in here and see you with some information ahead of time. That's kind of sort of what I did when I was in medical school. And I think that that simple introduction sort of sets the expectation of what you can expect and what the patient can expect from you. I do feel like at times people can be hesitant to perform the physical exam or feel like maybe perhaps they're doing something, especially if it's something that exacerbates pain, such as a stitch field or a straight leg raise when you're evaluating somebody with hip discomfort. There can be some hesitancy to want to move forward with that, but I think it's an important part of the learning environment, and it's something that you've got to do. And it's just like operating and even taking a history. The more you do it, the better you're going to get. And the physical exam is definitely a skill that needs to be built, and building that as a medical student and earlier resident is critical. So it's something that I think you should definitely do and have the diligence to kind of take pride in.
Yeah, I think one thing you mentioned that I think is really important is setting expectations with the patient. When you go in the room and you introduce yourself as the medical student, let this patients know right off the bat before they can really almost get a word in that you're there, you're the medical student, you're there to get information, and you're going to go present it to the PA, whoever's going to go see the patient, the attending, so that they know that they're not only going to be seen by the medical student. A lot of the fears for patients when they come to clinics and they get seen by a medical student is that they're not going to be seen by anybody else, that the only history, the only physical that's going to be done is by the medical student. And so letting them know that that's not the case will oftentimes let patients kind of open up and let them be a part of your care. And then you can kind of go forward with that. And then lastly, kind of one of the big parts of clinic is the presentation. We don't have a lot of time in clinic. We're often triple booked. And so getting all the information you want to out in a very succinct manner is super important. And so the things we kind of really want to know is why are they there? What is a very short history of their symptoms? What's unique of their physical exam, and then kind of what have they done, and then a plan. A plan is part of way you can present yourself as knowing a little bit about the history and you've worked through the patient's problems, and then you have a plan. Your plan doesn't have to be right, but you should have a reason for why you have your plan. Yes. Dr. Ager, I'm going to bring you in here. You have a very busy clinic and oftentimes have medical students in there. What do you find the best medical students have done when they've seen patients grab charts in order to kind of really hit home on the presentation?
Yeah, I think you hit the nail on the head. Being articulate, succinct. I don't need 3.5 minutes of yeah, da 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 da, and then after that, this next thing happened. We kind of want to keep moving. I mean, a lot of times when the med student is approaching me, we're like ships in the night. I'm already headed towards that room, and you got about 10 seconds to get it all out. So you got to find a way to get it all out. One thing I was going to mention from earlier, though, is the importance of the students being proactive, in asking the attending, introducing yourself and asking, hey, is it okay if I grab some charts and see some patients and present them to you? It's amazing how many sub-Is show up and they're like, hey, what do you want me to do? What do you want me to do in clinic? And instead of being passive, I would encourage them to be as active as possible, not aggressive, but active, and inquire, hey, how can I help? Can I see some patients? And then go for it. I mean, it's a sub internship. Act like an intern. Try to act like a resident. I think that'll really set you above your peers if you really charge at it rather than kind of just puppy dogging the residents and the fellows and the attendings, which is okay if that's what is expected of you. But I think all of us really open our eyes a little wider when we see a gung-ho student that's really going for it.
I think to follow that up, I would say that when a medical student or even a resident comes to me and says, what do you want me to do in clinic? My answer to them is, I want you to do whatever's best for your education. And I leave it at that because that is what I want you to do. So if you think that following me around is best for your education, I don't think that's what's best, but if you think that's what's best, you can go for it. I love what Dr. Aker just suggested, which is like, can I grab a few charts? Is that okay with you? That's not aggressive. It is just proactive. And the answer will absolutely be yes, because that shows some initiative. And I think that you, if you're the type of person that's asking that question, you know that that's what's best for your education, because it is.
The last thing I would touch on is be very careful about what you say to a patient when you're the medical student. I would be an information gatherer. I would get the physical exam, and then I would say, you know, I'm going to go talk with my attending, and then we'll be back and discuss. And then when you present to the attending or the resident or whoever it is that you're in clinic with, then you can start to make plans and you can talk about things, but oftentimes patients can latch on to certain words. And so just a caveat there that we want you to be critically thinking, we want you to make plans, but that's best kind of kept for the back rooms to talk to the attendings and then kind of hash out the plan and then go back in and the attendings can kind of talk about that. Always introduce, we touched on this, always introduce yourself, who you are and what you're going to do. Patients are a little nervous about people that they don't know who they are. You know, a lot of times they know who the doctor is going to be, or they've seen them in the emergency department or something like that. But the medical students, just tell them who you are and what you're going to do. Again, be very kind of vague about treatment plans to the patients. It is okay for patients to refuse certain parts of exams, or, you know, oftentimes patients will change stories. We've all been medical students where we obtain the history. We know exactly what the patient said. They go back in with the attending and they say something totally different. It's okay. We know that happens. And like Ellie said, don't make anything up. Be honest. If you didn't perform something, that's okay. All right, we're going to move on to the ER. Please keep answering or asking questions if you have any. Hopefully we're bringing up some important information that you have some questions about. But we're going to lean heavily on Ellie and Eden here for the next part because fortunately in our lives we've graduated from the emergency department. Some of us on the call for some of this. So this is a 16-year-old patient that presented with left hip pain. You know, oftentimes the residents have 3, 4, 5 consults in the emergency department. Eden, you're going to send the medical student down there, you know, because you're doing a hand lac. You're in the middle of a nail bed repair. You're trying to hit your pager with your non-sterile hand. Phone's going off. Can you go get a history? What do you want your medical student to come back with if this is the X-ray that they've seen?
Yeah, so I think this is a really good case because I think like this actually happens a lot at busy trauma centers. So I would definitely want to send them down there and start like get a history, like a basic history, make sure that they're neurovascularly intact. And of course we always check the exam after them. But I always tell them, like, as I am getting the x-rays up and calling people, I'm trying to set up a sedation. So I'm calling the emergency department, trying to get timing on that. I'm telling them probably to start getting traction. If I think there's like a, you know, an acetabulum piece. I'm asking the medical student, in addition to supplies and history, to get just to really just push all over the patient, because while their hip really hurts, if it's this high energy, there's a high chance that they'll have other injuries and they might not notice it because they're distracted by their hip pain. So I just tell everyone, and I do it myself every single time, is push head to toe, find other injuries. And then if you find other things, of course, start getting supplies for those. Those are the main points here on this slide. We can go into more detail in a second as we show more of the x-ray.
Yeah, I think that's, you know, you want to return to the resident you're on call with a pretty concise history of what happened, a good physical exam, and then any other things that you're concerned about injury-wise. You know, oftentimes these patients, like Eden said, are polytraumatized, and you can find other things that hurt them, even though their left hip is what really is hurting them at the time if you push on patients. So kind of a tertiary exam, just pushing on everything, or a trauma survey.
I think too,
So,
can I just chime in?
yeah.
For things like this, for like a native hip dislocation where time matters, doing it with a sense of urgency too is really important. So like going down there, getting all like your history and your physical, like we've talked about, but then going back and telling the resident right away. Don't just like meander down to the ED and like wander off. Like go there, get the history, and then you can also go back and ask the resident, you know, if they are scrubbed in doing something else, like, okay, now what can I do next? And that might be setting up traction or getting sedation ready, things like that, so that things always move forward, because otherwise this patient could sit there with a dislocated hip for a long time. That's obviously not what we want.
Yeah, I think going off of that too, like Ellie was saying is, and we both mentioned like getting a sedation ready and getting the supplies for the traction, getting a hospital bed if they don't have it, making sure you have enough weight, like all these little things add up. And even though each task alone only takes maybe a couple of minutes, like if you add them all up, it can take 30 minutes, an hour. So that is huge. If you can bird dog the sedation, the supplies like ready, locked and loaded at the bed, so that when, you know, when we come down, we're ready. And then we trust you more and we'll let you do more and more as you show that you know what you're doing.
Yeah, I don't think anyone expects the medical students whose first day on call at a new hospital in a different place expects you to know where they keep the traction, right? So asking questions on your first call shift is okay. Don't need to be scared and wandering around for 2 hours trying to find the traction on your own. Like, people know that your first call and your away rotation, where you have traction. But if I had a medical student on call with me and I was a resident and they saw this and they came back to me and they were like, oh, they're the sensation and the perineal nerve distribution is decreased, but they have 5 out of 5 motor strength. Where do I get the traction? That's something that's would be really impressive to me. They know that this injury needs traction and they're wanting to go get it, and it'd be like, great, it's here, or hey, it's actually in a weird spot, let's go get it together so you know where it is next time. That's something that shows a lot of initiative and understanding of the injury. These are certainly things that need reduction and urgent reductions, like Eden said. And so beginning to start working on sedation, and then being able to position yourself. If you can position yourself so you're holding the pelvis while the resident is starting to do the reduction, is something that shows you understand that you know what the next steps are. And then you're kind of working as a team, you're jiving. Part of being on call overnight is with a good medical student is super fun. You got someone who's really helpful, and the two of you are kind of a team working together. And so hip reductions, there's a lot of different ways to do it. We got the Captain Morgan technique, we got the hero technique, standing up on the bed. Then we have the technique with people who don't have ACLs, so they just kind of try to keep their 2 feet on the ground at all times. But it's certainly something that you can contribute to. And if you know that we want to stabilize the pelvis while we do a reduction of the hip, you got the traction. That's all signs to show that you understand the process, you understand the injury, and you're helping out the resident. I think one of the things that was told to me as a medical student is try to replace the person above you that you're working with. So if you're the medical student, try to replace the intern. Try to make the intern's job so that they don't have to do anything. Then the intern is trying to replace the 2, and the 2 is trying to replace the 4, all that stuff. I think we can briefly go over this, but there's 2 places to put traction: distal femoral traction, and this is what that looks like with the traction bow. But I think mostly important for you guys is, the parts that you need some type of power, manual or power to put a pin in. You need a pin, you need a bow, you need rope, and you need the traction setup for the bed. It's not a lot, but it is a fair amount of stuff. And, the residents are getting 4, 5, 6 consults at a time. That's something that you can definitely help out. And it's not, in my opinion, scut work. It's something the residents got to do. And so it's something you can help out with, and is super beneficial and time saving for the residents. Proximal tibia traction is just a different place, but it includes all the same type of equipment. So this patient underwent,
Interrupt you
exam-
quick,
Go
Pat.
ahead.
As far as like all this equipment that you need to, like kind of like we've already said, we don't expect you to know this on your first day. But if we show you what you need for traction or a specific splint, like write it down so that the next time you need to go get a splint for a sugar tongue, like you know exactly what we need to get. We don't have to tell you again, like, oh, you need 10 sheets of, this size. So write it all down somewhere, like on a sheet of paper, on your notes in your phone, so that it makes it faster the next time that you can go do it on your own. Because the more proactive that you are in doing all of this, the more time that we have to let you guys help reduce things, help splint, and get you guys more hands-on time yourself, I think is really important.
I think all of that is super important so that you can be able to get yourself the opportunity to do things. Again, it's like suturing, right? If you start to bring all these equipment, you get all the stuff set up. The second time you're on call, you have the sugar tongue splint. Maybe by the third time, the residents are kind of going to let you do something. And so all this stuff of being prepared and helping out gets you the opportunity to do more. Ellie, what kind of, this, you got a resident or a medical student with you on call. This is the second wrist fracture you've seen that night, and they're on second week of service. What are you hoping kind of when you go see the patient that's going to be there?
As far as what I want the med students to get,
yeah, what are you hoping, like when you walk in the room or right before you walk in the room, the medical student's going to kind of present something to you, and then you walk in the room and you're hoping what's going to be there?
Yeah. So I kind of think I like to think through like what we would need for reduction. So it depends on if you guys do a hematoma block or a beer block or just different ways to like numb up the arm. So some sort of lidocaine, a tourniquet if you're going to do a beer block. If you do a beer block, it's a specific type of like local anesthesia. You can numb up the whole arm, but you need an IV in that actual arm that's injured. So that can be really helpful finding a nurse to do that. And then thanks for a sugar tongue splint. And then so sheets of like 10 sheets thick of 4-inch plaster. You need ace wrap, cotton padding, and then if you have them, is finger traps, so something to hang the arm. And then an IV pole. So a bunch of things, but if you think through the process, if you need to reduce it and then you splint it, and then you'll need post-reduction x-rays, hopefully you can think through like all the materials that you need to get. I think that's everything.
Yeah, so that might sound like a lot, right? Ellie just went through an entire distal radius consult, and that's kind of overwhelming. Maybe at this point in your training that you're going to have to remember all those things. But by the time you finish your 2-3 AIs, you're going to see so many of these distal radiuses that it's going to become a second nature to what you need. A sugar tongue splint is something we routinely use for distal radius fractures, and it really gets its term from sugar tongs, the tongs that you use to get ice or sugar out of a bowl. It's just a giant U that goes around and provides stability to the wrist. This is a wrist fracture that was seen in my emergency department when I was on call, and the residents performed a really nice reduction with an adequate splint placement. And the residents on service where you're at will go through all the little tiny specific details of where a good sugar tongue is, how to pad. But I think something to talk about, and what we talked about, is what are the supplies you need? I think when I was in residency, we had different types of plaster, but you need a certain amount of plaster, you need a certain amount of cast padding, you need a certain amount of ace wraps, you need a basin, the lidocaine for a hematoma or beer block. All that stuff is you can kind of start to get together that allows the resident to do other things. And then one thing I want to touch base, Eden, how helpful is it for the medical students to know how to hold limbs?
I think it's really important. Again, like we never expect you, if you've never done anything, to know the first time, but it's really, really awesome if when you do it once or twice, then you can reproduce it, and then we can trust you. Because if you are moving the arm around as plaster is hardening or as we're molding, especially with like casting at peds, we want to avoid creases and places where skin, like sores and wounds, can develop. And we want to hold the reduction, of course, appropriately. So holding it like in this picture is super important. And it helps us also just wrap more quickly, more efficiently, saves time. So huge if you can do it. I'll also add, just related to all of this, that a lot of residency programs have created documents that are specific to their own programs. Like Vanderbilt has one that we typically circulate to our rotators and home students. And then definitely UT Houston has it. I'm sure Utah had one, of like codes to doors, exact supplies that residents want, where to get them, and all of that. So when you rotate at places, like feel free to ask, like, do you guys have like a med student call guide? And like if that place has it, I'm sure they'd be happy to circulate it. That can help you start creating those supply lists that we've been talking about.
And I think the other thing I want to mention is, you're learning. You're trying to learn different ways. You're trying to learn all the different things that happen. And when you go to an institution, they're oftentimes going to do things differently. You're used to how the way your home institution does sugar tongs. You're used to the way your home institution does traction. And oftentimes you're going to realize that there's different ways to do it. And the opportunity to suggest that may not be the way that it's done somewhere else is not on call with the resident. It's to learn their way and to kind of soak in all that knowledge. And then as you become a resident, you're on your own doing things, you can amalgamate all of your knowledge that you experience on your away rotations as well as at your home institution to make a way that you do it. So that you don't, but on the away rotation is not the time to kind of say, oh, that's not how we do it here or something. So just kind of try to fit in with how people do things at their institution. There's a reason. I'm gonna breeze through this briefly because I think Lucas has a lot of important information for the OR, which I think is one of the most important parts of the medical student rotation. This is just another common injury that you'll see. This is an open ankle fracture. And I think some of the key things that I want to talk about just briefly with you guys is that oftentimes you're the first person to see the patient and you're the first person to see the wound. So we didn't always have this, but now it's so easy to have a camera on a picture or a camera on a phone, take a picture of the wound. And if it can get reduced or something, but take a picture of the wound and then try and cover it up so that you can show things. But the faster you can cover wounds up and keep them clean, the better. So take a picture so that people can see it, the attending, the residents, the fellows, and then help to start coordinate urgent reductions of these limbs. Splinting, learning how to hold limbs so that you're not squeezing the toes here and you can only hold it for about 45 seconds as opposed to keeping your arm straight in positions that you can hold the limb in for minutes to 10, 20 minutes without getting tired. So I'm going to turn it over to Lucas here to talk about how to get prepared in the OR.
So we've already talked about like 2 of the 3 pillars we're going to talk about tonight, kind of the clinic and consults or the emergency department. The last thing we'll talk about today is the OR. We sort of saved the best for last. This is why people do orthopedics. I also think that this is probably the source of the most anxiety when you're a medical student, or at least was for me, right? You're kind of entering this pseudo foreign environment that you don't have that much exposure to through medical school, and you're trying to make an impression on people. And it's honestly the time where you get the most interaction with the attendings that you're working with. And so there are just a few things that I would consider basic etiquette for the OR that I've outlined on this slide. The first thing is find a place to write your name and introduce yourself to everybody in the room. That doesn't mean just the resident and the attending you're working with. That means the resident, the attending, the scrub, the circulating nurses, other students that may be in the room. So that could be, scrub nurses or scrub students or nursing students. Even introducing yourself to the anesthesiologist if they're in the room, I think is 100% appropriate. There is always a role for you in every point of a case. Your role at some point may be to just not be in the way. Like that sounds silly, but it's true. That could be something that's vitally important to the surgery is to just give us a break, make sure you're not in the way of, say, the fluoroscopic machine. And at times when you can help, it's very when an attending asks you to hold a retractor, be on top of it, pay attention, don't relax, like be engaged in the surgery. It's also okay, similar to what we were highlighting about in clinic, to say, is it okay if I grab a few charts? It's also fine in the OR to say, what can I do to help? And it may be the answer is right now, nothing, but that sets the stage for me to invite you to help at a later point in the case. I may not even be in the room, and it may be you and the resident preparing a limb, positioning a patient. It's okay to ask the resident the same question, what can I do to help? Or even be more suggestive or active in that, such as, is it okay if I hold the limb while you prep it? Or is it okay if I help you prep the limb? And the glorious thing about those conversations is they really only have to happen once on your rotation, because then you're going to figure out what is okay for you to do. All right. It's important, I think, and valuable to grab your own gear. So that includes grabbing your gown and your gloves. And then we're going to talk about in the following slides how to come prepared in 3 simple steps. Okay. And before we move on to the next slide, I would like to first invite Ellie and then Eden to sort of offer up things that they found helpful when they were residents that medical students did in the OR, and subsequently what sort of things, if there's anything I missed on this list, that they did as medical students.
Yeah, I think you mentioned a lot of the things that are really important. The other thing that I just wanted to add is just having some sort of situational awareness is really important, as far as, you already mentioned the x-ray machine or the fluoro machine. But also just as far as like you and maintaining your sterility is really important as a medical student. And every one of us, makes something unsterile or contaminates it. So if somebody says, oh, you contaminated yourself, like you should get a new gown and gloves, like don't argue, just get a new one. It happens all the time. But then the only other thing is like maintaining your own personal space, as far as like, we all know you want to see in the wound, but sometimes the wounds are not big enough for everyone to see. But we all need space to like operate with our arms and our elbows. So just taking your time, learning how close to stand, or how to hold retractors, I think is really important, because then it sets you up for success for like when we can be like, okay, here, now why don't you come look at this, this part of the wound or this anatomy. So just kind of having some sort of situational awareness is really important.
Yeah, and I'll add just really like pattern recognition. So little things that I appreciate when medical students do now, and tried to do as a student too, were getting to the OR like early, making sure everything, was in the room, including everyone's gear. I would offer to always get like gloves for residents if they were in a rush doing things between cases. I would help move the patient from bed to bed, move the bed out of the room once they're, ready. Just little things like that. And then, of course, always offering to hold the leg for the prep. And then while you're in the case, pattern recognition of like, if you know that the basic steps of, let's say, putting, drilling for screws and putting the screws into the plate are always the same, like you can kind of anticipate and work with the scrub tech to make sure that instruments are getting handed like efficiently, and just things like that. So you can kind of just pick up on things as you go.
Yeah, I really love that concept of pattern recognition and finding the little things you can do, because it makes you feel valuable, engaged, and part of the team, and it sort of boosts the morale of everybody, I think, in the room. So we can move on. Yeah. So did we skip one slide there, Pat? Yeah. So I think I had mentioned there's basically, for me, and I think for medical students, there's 3 steps to prepare for a case. So the first one is to know the patient and the surgery that's going to be performed. So knowing some basic history about the patient, their demographic data, and what injury they have goes a long way, as well as if there's any extenuating circumstances that may change the surgery you would propose, i.e. the patient has a history of cancer and may have metastatic disease, et cetera, et cetera. Doesn't have to be an in-depth knowledge of everything or the medications the patient's on, but you got to know who the patient is, what their injury is, and what the surgery they're likely to get is. That's going to set the foundation for what you do. That's going to then allow you to move on to step 2, which I think is critically important for medical students, and that is to know the anatomy. you're not going to know everything in the OR. You're not going to know every question an attending asks you, and you're not going to be able to execute the surgery that the attending and the residents are performing. If you could do all those things, there would be no need for you to be a medical student or resident. You could just therefore be doing my job. So you're not going to know everything, but the things you can know, cut and dry, are the anatomy. What resources, Eden, did you use to study for anatomy when you were a medical student? And maybe still as a resident, I'm sure you're still refreshing and learning anatomy as you move forward through residency.
Yeah, definitely. I use definitely AO surgery reference. I thought that was good for a lot of the very common things that you'll see. Um, I would I would make, even drawing it out just simply like help me remember it too. I would talk to residents too and just make sure like what I thought was happening was actually what they thought would happen so that you're not, accidentally preparing for the completely wrong thing. Um, I would also use like, any textbook with the approaches. A lot of residents have PDFs of them that they can circulate to you so that you don't have to buy a hard copy book. And then another thing that I still love is any sort of like anatomy app on the phone or an iPad that is 3D anatomy that can help you with the 3D orientation of, and even like the, superficial deep layers and everything like that, and just relationships between anatomic structures. So those are the main ones.
Yeah, those are all great resources. The AO Surgery Reference, which you can download as an app on your phone and visit on a website, are great. I don't say that just because we're on an AO webinar. Those are useful. They're still on my phone today. And then I really love this textbook, which is everybody refers to as Hoppenfeld's, but Surgical Approaches in Orthopedics. It's a great text with a lot of detailed anatomy and great illustrations. And then finally, you're going to move along to step 3, which is sort of a continuation of step 1 and 2, which is knowing the patient and the surgery they were going to do, is understand the basics of the procedure that's being performed. That could be a plating or a nailing. There are lots of ways to learn about this. I personally think that this is the one part of the procedure that's great to ask residents and attendings about before or after a surgery to gain their knowledge, because there's almost unlimited resources to learn about this. There's a lot of creativity, particularly in orthopedic trauma surgery. And so getting the gist of the team and some of the inside scoop, I think, is sometimes more beneficial than reading about a stock fixation of a patella fracture, say, out of a textbook. So here's a first case. This is just a basic ankle fracture. And I think, a point of this webinar is to not go over every injury or every patient you're going to see in clinic. There's simply too many types of injuries. There's too many details. We can't cover it all. We're trying to give you large bucket items to focus on here. So we don't need to focus on necessarily the details of this specific type of ankle fracture. But Ellie, as a medical student and even as a resident, can you tell us a little bit about how you prepare or go about preparing for scrubbing in on a case to fix this ankle?
Yeah, so it's a little bit different now that, I'm farther into my training, or at least when I was a medical student. So, you want to look through all of the x-rays and the CT scans and know where the main fracture fragments are and then how to get there. So for example, for this one, you can see there's a fairly large posterior malpiece on the 3D CT scan in the middle, and then there's a high fibular fracture and a medial malfracture. So, there's 3 different fractures. You have to access them in 1 or 2 ways. And so looking through Hoppenfelds to see what approaches you can do simultaneously or do multiple approaches without having too small of a skin bridge. And then I would use like the AO website to see like different types of fixation. I think even just knowing that basic, like how to approach it and what to use, I think is really important. And now as you progress through like residency, having a written out plan of exactly your approaches, the hardware you're going to use, etc. I don't think anyone necessarily expects you to have a written out plan, but just at least knowing, okay, you want to fix these with plates and screws versus an intramedullary nail if you're doing long bone fracture, will just set you up for success. I don't know. Yeah.
Yeah, I think that's perfect. And that what you said about not knowing the specific details of how to execute the surgery, I think drives home my point. Those are the great talking points to have after the case with the attending fellows or residents that you're working with. So normally you identify the injury. She identified that as an ankle fracture. Ellie then talked about the relevant anatomy and how she would prepare to understand that anatomy using the AO surgery reference. Here are some shots. Yeah, no, I went to AO surgery reference to pull these images. I clicked on ankle fractures, identified the fracture that looked the most like the ones on that x-ray. And I said, what are the approaches that somebody would use to access these fractures? And then I could read through what a surgical approach looks like, what the dangers are from an anatomic standpoint, and get a good grasp of the anatomy. And then finally, on that same app, they can give you an idea of what procedures you may expect to see a surgeon perform during these cases, and you can at least learn the basics about fracture fixation through the app as well. So we have a couple more cases, but I really think that one case illustrates what I'm trying to drive home for you guys in terms of the basics of preparing for a surgical case. Knowing the patient, knowing the anatomy, you got to have the anatomy down pat. Those are the questions you're going to be asked, and then having some idea of what the surgical plan will be. And with that, we'll come to sort of the last 5 minutes of the presentation, which is what I think you guys probably sat through this presentation for. We had a meeting before giving this webinar, and I think I told the moderators that this is the most important 5 minutes of the talk from my perspective for you all. And so we'll spend a little bit of time kind of talking about the basics. And I'll tell you that I put in there, I can't believe that I have to say some of this out loud, because to me, a lot of this is common sense. But those are the most common mistakes, unfortunately, that we see medical students make, at least in my opinion. And again, there's a giant caveat that I shared with you all at the start of this webinar, which is that these are the opinions of 4 like-minded people, probably not shared by everybody. But here are a couple things that I think are important for you, starting off with arriving early. I think Pat had kind of an interesting anecdote about arriving early, or something that he notices at his center from time to time. So I would encourage you to share that with everybody, Pat.
Yeah, I think that the residents are making lists in the morning. There's a lot of specific parts, but when medical students show up right when the residents are starting to run the list, right at 6 o'clock, because that's what they were said that's when you start showing up. This is something where you can start to set yourself apart, right? I'm not mad. That's when you were told to start up. But if you show up at 5:30 and you start helping the residents put something on the list, you can help looking up. Maybe you can tell them where the rooms are because the red cap, or you can look up some cultures. These are all things that are going to go a long way for you to show that you're engaged, you're wanting to know what's happening, and sometimes you may have to go see a patient pre-op or before the start of kind of sign-out rounds. But that's something that's always important, that if you arrive early, you can always be doing something.
So that kind of sets the stage for the day, arriving early. I think staying off your phone and staying engaged is incredibly helpful. And so because of this, I'm going to share something, because Eden was talking about people sharing PDFs with you about like surgical approaches or anatomy on your phone. I personally like the idea of having those on an iPad or something that is not a phone, that suggests when you're sitting around looking at this, learning about anatomy, it doesn't look like you're just looking on your phone. So there's going to be a variety of opinions on that front, but that is my preference, is that you either have a pocket text that you're reading from, or an iPad, or something that doesn't make me think you're checking a soccer score on ESPN. Here's a big one, and maybe one of the more common mistakes I see people make, I think, is you should take your breaks when the team takes their breaks. You should eat your food when the team's eating their food. I think if you're going to truly integrate yourself as part of the team, then you should act and behave like a team member. So if the resident doesn't have time to eat or take a break, it probably means that you won't either, because if you're trying to be helpful, you will be equally busy as them. Eden, do you notice this in rotating medical students, or has this ever been something that has stood out to you?
Yeah, I mean, we talk about all the time, like all the really good and all the really bad too. We've noticed both. We've noticed this is an example of a pitfall of, like, you're in clinic or you're on overnight call shift, and you just disappear and no one knows where you went. And then they like find you eating like chicken and rice like in the workroom. Um, that doesn't look great, because you know that the resident on call is just as hungry as you are, and you've just left and you haven't been helping for an hour. And so that's a pitfall. And then like Dr. Marchand was saying, like you break when the team breaks. So that's like just taking, situational awareness, social cues, and pattern recognition. A lot of it's just reading the room.
Yeah, I understand that you take pride in the chicken parmesan you made, but I don't really want to watch you eat it while I'm starving and reducing an ankle down in the emergency department. It's kind of how I feel about it. So, asking relevant questions and exploring genuine curiosities is something that I can be important for you. Typically, if you're deciding to go into orthopedics, a lot of things excite you. Something that drives me nuts, particularly in the OR, is when I can tell somebody's asking a question for the sake of asking a question. There's no need. If there's something that you're genuinely interested about or you have a curiosity about, you should absolutely ask. And I'll tell you, it's very obvious when that's the case and when the former is the case, i.e., you're just asking a question to ask a question. So it's helpful to not pre-plan what questions you're going to ask. Let it be spontaneous, come up in the heat of the moment, and ask the things that you're truly interested in learning about. I also don't like when you, or I don't think any of us probably like when you're asking a leading question, i.e., I'm asking you a question so that you'll ask me a question so that I could show you how smart I am. That's not getting any of us anywhere. And if you already know the answer, there's no point in traveling down that rabbit hole.
And I think if you prepare too for cases, like those questions will come up more naturally. Like, why did you use this plate versus a nail? Or why are you lagging a screw and then putting a plate on versus just putting a plate on? As you prepare for cases more and more, you'll understand little nuances between why we decide things. And I think that'll just help you ask more relevant questions in the OR.
Finally, keeping it professional, I think is critically important. What I mean by that is everybody wants to share a common goal and have some camaraderie. But ultimately, you're a medical student, they're residents, we're attendings, and this is a workspace. And that's how it should function. Okay. It should stay professional. This is a common pitfall of rotating medical students, I think, at times is feeling too comfortable within the setting and perhaps pushing the boundaries, which can be off-putting for both residents, attendings, and fellows alike. And then we're going to just bookend this basics with staying late. This really harkened back to the break when the team breaks. If the residents are sticking around till 7 p.m. doing work, I would expect the same as you because that's how we would expect you to function when you're a resident. So leaving at 5 o'clock because your shift ends or you were on call the night before when the resident that has burdened equal or more workload doesn't make a whole lot of sense in my eyes. And I think overall is sort of a bad take for rotating medical students.
Taylor, I know you've been on this whole time. We've been ignoring you, one of the OG AO winning faculty here. Anything you want to add about the, common things that you want medical students to do just overall to get garner them some success?
No, you're good. I'm just a fly on the wall. I was observing, but I do really love those points about pattern recognition for sure. And I would say that one other thing maybe that didn't get touched on is sort of no task is below you, right? Like I'm sure I got interviews from cleaning up poop, okay? And so there's no task that is below you.
Perfect. So, I think the take homes from this, hopefully you got some pointers on how to succeed in the clinic, the OR, and the emergency department. They all have different but very specific demands in which the medical student can have a real important and beneficial role that can help out the entire team. And I think most importantly, the patients. I think you can really affect patient care by making things happen quicker for residents so that they can take care of patients in a more efficient manner. Be prepared, work hard, always try to get better. Every day, try to learn something, try to show up and say, how can I be better than yesterday? And I really love the word, I've tried to explain this, but I really love this pattern recognition. It's totally what it is. It's pattern recognition. And that's all, that's orthopedics, that's ACL tears, that's trimalleolar ankle fractures. that's also getting better. That's also learning pattern recognition. And I think the other thing that I'd like to say, because Dr. Marchand was one of my mentors in residency. Find yourself somebody in the residency that you think is a really awesome resident, that you think really works hard, really knows their stuff, and then go ask them questions about how they prepared, how did they get where they are, and just model yourself after them. Do what they do. If you can emulate the person that you think is the best resident in the residency, then you're going to be pretty close to that person. I think that's kind of one thing you can always do. And residents really appreciate when they get recognized as a good resident. They're more than happy to help you, tell them how they improve. And lastly, make sure you got your credly badge. We want to thank everybody for sticking in for a little bit over an hour. Hopefully this was super helpful for you. If it wasn't, I apologize for you sticking through the hour, but we hope you got some take-home points for you to succeed over the next couple months on your away rotations, or if you're a third year, second year, first year, coming around the orthopedic service. These are all good pointers for how to succeed. I'd like to thank Ellie and Eden for taking their time out of their busy days to join and give their opinions, as well as Dr. Aker and Dr. Young for coming on and giving the elder statesman advice, and as well as Dr. Marchand. So